We'll get started here. Well, good afternoon, everyone. Thanks for joining us today for Physician Partners of Western Pennsylvania lunch hour monthly webinar. So we appreciate you taking time out of your lunchtime to meet with us today. And I really enjoy these times. It's a great opportunity for us to reconnect and hear what's happening within the network, some of the exciting things that are going on, and for all of us to learn and grow. So appreciate your time. Just a few housekeeping items here. First off, just remember to keep your line muted unless you are engaging in the discussion, asking questions. We do welcome that throughout the presentation. Feel free to join in the dialogue. You also can send your messages or questions through the chat function as well. We will be recording today's presentation and also offering CME. The information regarding the CME will be provided, how to register at the end of the presentation today. Joining us today, we have Tina Hahn, Ambulatory Quality Director at AHN. We have Dr. Frank Colangelo, who is AHN's Office Director, Outcomes Office Director, and also Chief Quality Officer at Premier Medical Associates. And then we have Cynthia Rice and team from Grove City Primary Care, who will be sharing their experiences as well. And we are, again, offering CME, and there are no conflicts of interest to disclose. So let's get into the objectives. First off, we want to understand the why behind clinical quality gap closure, discuss some priority quality metrics and some of the best practice workflows that exist out there, along with some of the specifications around some of these metrics. Review some strategies to proactively identify and care for the needs of our patients. And then some of the best practices, as mentioned, will be shared by Dr. Colangelo and Cindy and team from Grove City. So let's get into it. This topic of addressing clinical quality gaps is a bit of a loaded statement. There's a lot behind that term. It can be a very technical conversation if we're talking about how to close that clinical quality gap from a payer perspective. There are measure specifications, there are inclusion, exclusion criteria, there are dynamic and static measures. So there's a lot of technical aspects to this, but and I think that we will spend some time today just zooming in and understanding some of the details behind that. But I'd like for us, and if you just go back a slide for a moment, I'd like for us to zoom out for a second and just say that, it is truly about providing good care to our patients. It is about us delivering the best care to the patients, improving both their quantity and quality of life. And I think just taking a pause here to say, we're going to get into some technical things, but think about the patients that we're touching. And at the end of the year, I hope when you look at your quality data, you can think about all the patients and the lives that you've touched every year, improving their quantity and quality of life. So next slide. It's important to remember that all of these clinical metrics, quality metrics that we work on every year are all based on clinical guidelines that have been published. Many of these come from the United States Preventive Services Task Force, who has provided recommendations around things like colon cancer, breast cancer screening, and others. There's also the American Diabetes Association and other specialty societies that have put out recommendations regarding diabetes care and how we can best improve the lives of patients with diabetes and prevent those downstream complications. So I think it's important to recognize that even though these measures are very complex, they're all based on some fairly simple clinical guidelines. Next slide. When it comes to executing and when it comes to actually closing a quality gap, there are several steps along the way. We have kind of listed here some of the common steps and the areas where challenges exist. It really does start with taking a look at the interaction with the patient. So first it's identifying that a gap exists and then initiating an outreach to that patient, making them aware that a gap exists. And that can be done either through kind of a proactive approach or more reactive when the patient arrives to the practice, and being prepared to address those gaps during the visit. There certainly are patient engagement challenges that can occur where there may be barriers that the patient has and either understanding the importance of it or being motivated to complete the test. But if we just zero in, this is probably one of the most important steps right here, is the patient has to take action. They have to understand the why behind each of the quality gaps that exist in their care. But if we address those things through outreach and motivational interviewing, I believe that we can get a lot of patients to agree to the recommendations that we provide. Further downstream, once the test or procedure has been completed, then there is a bit of a lag that occurs. And this is the sometimes just a wait and see approach, wait and see that the claim has been processed, and from a payer perspective, that gap has been closed. And there are times when the gap does not close and we need to intervene on the back end in terms of a claims gap process, and whether that's submitting additional codes or using a feedback loop that the health plan provides. Sometimes we need to provide some manual input to make sure that the payer is aware that this clinical quality gap has been closed. So with that bit of background, I'd like to go ahead and encourage us now to go in and look at some of these priority measures that we are talking about here. We have chosen 5 to review today, and I'm going to hand the baton off to Tina Hahn to talk about some of that detail.
Great, thanks, Dr. Reynolds, for for setting the stage. We're going to talk a little bit about the specifications around these measures. I think many of us are familiar with them, so we won't go into great detail, but maybe talk a little bit about the nuances of some of the measures. And if we can go to the next slide. These are the 5 that we're going to take a closer look at today. So some preventative cancer screenings, as well as controlling high blood pressure and a couple of diabetes measures. If we click once more, you can see sort of why these measures. Why do we want to take a look at these? And so first of all, if we can go to the next one, we want to really impact the patient outcomes, as Dr. Reynolds shared. And these measures give us an opportunity to identify potential issues that are occurring with patients and intervene early. And I think we all know the earlier the intervention, the better the outcome for the patient. Next click. They also cross-cut across several of our payer programs, and we have a little bit more detail so you can see which programs they are included in. And then finally, these are areas where we have opportunity for improvement as physician partners of Western PA. We've seen great progress in several of these measures over the years, and so I think these are ones we want to keep our eye on to continue to drive that improvement. And we can go to the next slide. So which programs include these measures? Well, it's pretty much all of our PPWPA value-based contracts for 2021. Breast cancer screening, as you can see, really crosses all of the programs with the exception of current state gateway Medicaid. Colorectal cancer screening, same thing. Controlling high blood pressure, which this can be a challenging measure, both from the care gap and claim gaps perspective. This one is included across all of our programs currently, with the exception of Aetna. Nephropathy screening, as you can see. Eye exam, it's not included in as many of the programs, but it's definitely one that it can be a challenge, particularly from the closing the claim gap. So we wanted to spend a little bit of time talking about that one as well. So we go to the next slide. So how are we performing in these measures so far? What you're seeing here is some 2020 data for our performance as PPWPA across our Highmark and Aetna programs. We don't quite yet have the full data for 2020 for Gateway, so we don't have that on the screen here, but you can see we have some definitely some opportunity for improvement, also some variability in performance by payer population, which may be more reflective of those claims gaps than true care gaps, but you can see some opportunity for improvement in all of the measures. We do perform well, certainly in nephropathy. You look at that 95%, 98% and think, well, gee, it looks like we're doing pretty well there. And we are, but the thresholds for that measure in particular are very high, typically around the 98 to 100% threshold, depending on the program. On the right-hand side, you'll see our performance over the last 3 years in 3 of the measures for our Medicare Shared Savings Program, which includes our Medicare Fee-for-Service members. So in that program, the measures that cross-cut are hypertension, breast cancer screening, and colorectal cancer screening. Again, really nice to see that progress over time, and so we want to continue to drive that performance. We can go to the next slide. So there are multiple ways that payers get information about whether or not a care gap has been closed. And the most typical way is through the claims process. So the submission of procedure codes, meaning CPT codes, or those CPT2 codes, which are $0 reimbursement codes that are basically a way of reporting information to a payer. And all of the payers accept CPT codes and CPT2 codes. Some of the payers also have other ways we can get information to them, including clinical documentation feedback loops. So I'm sure many on the call are familiar with that process that you can submit through, for example, Highmark. You can submit data through Navinet. With Gateway, they also have an online process that you can use to submit some data. Several payers now accept data electronically from provider organizations, and they set up essentially an interface between your electronic medical record and their claim system, and can collect some data in that way. And then Medicare Fee-for-Service is really a kind of an outlier in terms of how data is reported. We report annually to them currently. There are going to be some changes to that in upcoming years, but we report through something called a web interface on a sample of patients. And go to the next slide. Okay, so let's take a look at some of the measures. We won't go into detail. We have a lot of the detail here for your reference. This information is also available on our PPWPA website, where you can find individual metric specification sheets that include recommendations for best practices for all of the quality measures that are included in our various VBR programs. A couple things to point out with the colon cancer screening metric. This is one where we'll often see claims gaps, particularly if a patient has had a colonoscopy, they may not need it for another 10 years. There's a good chance that patient may have changed insurance carriers during that 10-year period. So the payer won't have a record that that service was completed. Excuse me. Therefore, we have to use one of those other mechanisms, particularly in this case, submission through a clinical documentation feedback loop, to let the payer know that that care has happened, but they don't have a claim for it. We also know that there are several ways for this measure to be closed, several tests that close that measure, including colonoscopy, colonography, FIT, and FIT-DNA. There are some exclusions with this measure, as there are with every measure. One thing to point out here is that patients who are 66 years of age and older who have frailty and advanced illness are excluded from this measure. So while they certainly can get a colonoscopy, we certainly recommend that they get colon cancer screening, they are excluded from this measure. We do not need to report for those patients. In the appendix, you'll find all the details around the frailty and advanced illness codes. We've reviewed that in webinars past, but that's a strategy to kind of use when you're looking at your payer list to see patients who have care gaps. Are there patients that actually have advanced illness and have frailty that really we should be submitting codes to exclude them from the measurement? Multiple ways for multiple tests to close this gap, but pretty much these all happen through the typical claims process. So the provider of the colonoscopy would submit a procedure code to indicate that it had been completed. And then, as I mentioned, to close the claims gaps, this is one where we often use that clinical feedback loop. We can go to the next slide. Just a refresher on what the recommendations are in terms of the screening modalities. So tier 1 recommendation is really to use colonoscopy every 10 years. We all know that's the gold standard, but we also know that there are many patients who are reluctant to complete a colonoscopy. So the other tier 1 screening option is an annual FIT kit. Tier 2, you can see what the other options are. So first line, using those tier 1 treatments or screenings if the patient is not willing to do those. The options in the tier 2 will also meet the requirements for screening. We can go to the next slide. So breast cancer screening, similar in some ways to colon cancer screening in the sense that because this one does have a 27-month look-back period, meaning that if the patient has had a breast cancer screening within that time frame, that will close the care gap from the payer perspective. But if they changed insurance during that time period, there's a chance the payer will not have that claim. And so for this measure, we again want to use the clinical documentation feedback loop to get that information over to the payer. Frailty and advanced illness, again, does apply here for this measure as well. And then the next slide, please. So controlling blood pressure. This one is a bit more nuanced and really requires, I think, first and foremost, that we are taking blood pressures accurately. So that's a real key to success in this metric. The other key to success is ensuring that for our patients who do have elevated hypertension or elevated BP, that we are bringing them back for rechecks, or if the patient has a digital device, we can also check in with them through televisits to check on the status of their BP. This is what's called a dynamic measure, meaning that it is reported as often as it occurs in the year. So if a patient has 6 visits in the year, the BP will be can be reported 6 times, but the one that counts from the payer perspective in terms of closing the care gap is the last one of the year. So if that BP is not controlled, even though the 5 previous ones may have been, that the patient will remain open or have an open care gap or be non-compliant for the year. And so as the year goes on, as patients if they do have an elevated blood pressure, having a process in place to recheck that will be key. This is also one where you can see some claims gaps as well, because it does require the reporting of 2 codes for each measurement, a code to indicate the systolic blood pressure and then the diastolic. So that can get a little complicated at times with some EMR or billing systems. So just keeping an eye to make sure that your billing systems are identifying both the systolic and diastolic and submitting both to the payer. And then next slide. Nephropathy screening. This is a measure that can be satisfied in multiple ways, both through testing as well as evidence that a patient is receiving certain care, such as treatment from a nephrologist, dialysis, a range of things can satisfy this. They're on an ACE and an ARB. I think Dr. Klant is going to talk a little bit about, while several of these really satisfy the measure from a payer perspective, some may be more clinically meaningful than others when really trying to monitor a patient's kidney function. So measurement period for this one is annually. Same thing in terms of the frailty and advanced illness. If patients have certain conditions, they are exempt from this measure. And there are multiple ways that we can submit this as well. You can see CPT2 codes, those $0 reporting codes are often used for this measure. we can indicate that a patient has had a test, that it's been reviewed. And by submitting that CPT2 code, we let the payer know that we've seen that test, we've reviewed it, and that the patient is either positive or negative. And then finally, if we go to the next slide with diabetes eye exams, this is one where we often see claims gaps because the eye professional may not report the claim to the physical health benefits. They may bill it through the eye insurance rather than the medical benefits, and therefore the medical benefits payer does not always have that claim. And so there are some ways we can report that through those $0 reporting codes, and you can see the CPT2 codes there. And I think a best practice around this measure is, early in the year, for all of your patients who had, retinal screenings in the previous year that were negative, there is a code we can use, this 3072F, that indicates that the patient had no evidence of retinopathy in the previous year, and that will actually close the care gap for the current year. It doesn't mean the patient shouldn't still get their annual retinopathy screening, but from a payer perspective, a negative screen in the previous year will close the gap for the current year if we submit that 3072F code. So getting those submitted early in the year before things get too busy into the third and fourth quarter, that's a good strategy around the eye exam measure. And then the next slide. So those are the metric specs. What we want to talk about now is some processes that we can use to engage patients in in addressing these care gaps. And kind of how we can go about doing that at various parts of care, whether that's in the pre-visit, kind of pre-visit realm, during the visit, and after the visit. So if we can go to the next slide. It really all starts with that proactive population outreach, knowing who's on our panel, which patients are we responsible for, and proactively reaching out to patients, whether that's through a phone call, through your patient portal, through letter, leveraging whatever communication modalities you have at your fingertips and that the patients prefer. So doing that outreach is key. For patients who are coming in for visits, we also want to use the visit as an opportunity to engage them in understanding what their care needs are and planning to get those addressed. Pre-visit planning is key to that. Seeing what is the patient due for, which open orders may still be outstanding, and then alerting the provider and the care team that those would be good topics to discuss when the patient is in for their visit. During the visit, we want to treat every visit as if it's the last time we'll see the patient in the year. So talking with patients about health maintenance at every visit is an effective strategy. The other thing that's really key is keeping up to date on the care team, particularly when patients have external care providers. This is especially important for things like the diabetes eye exam, so you know which provider to reach out to get those results if the patient has had the service but the payer doesn't have the claim. And then when at all possible, we highly recommend scheduling the tests and services to address care gaps before the patient leaves your office. So if you're able to help them schedule that mammogram while they're there in the office, that increases the likelihood that they'll follow up and have that visit if they already have it scheduled before they leave. And then finally, post-visit. This is really important to keep in mind in terms of creating your workflows, is having a process in place to remind the care team members when to check back in with the patient. So that might mean running a report of open orders, scheduling reminders in your EMR system to check in with patients, in 2 to 3 weeks if that test hasn't been completed. And then if it hasn't been, then reaching out to the patient to see if they're having any barriers or need any assistance. And then next slide. And we really like to say that addressing care gaps is a team sport. It involves everybody in the office. And so the care team members are typically the ones taking the lead here in terms of identifying who needs outreach and getting things ready for the visit in terms of pre-visit planning, pending orders, and then they're often the ones who are submitting CPT2 codes and documentation to the payers on the back end. The providers, of course, play a very key role as well in terms of the patient engagement, discussing those care gaps, helping patients understand the why, and then outreaching to patients who are difficult to engage. So if the medical assistant or health coach or nurse in your office has tried and is really struggling with getting the patient to follow through, sometimes that phone call from their primary care provider can be the thing that really causes the patient to go ahead and get that service done. So that is a really effective strategy. And then finally, for those of you who have extended care team members like pharmacists, taking a look at what their recommendations are based on, particularly for medication adherence and other medication measures. They are having conversations with patients through medication reviews, and often have really helpful insights in terms of opportunities for the patient's care plan and ways to engage the patient. And then next slide. And so what does it look like when everyone on the care team is fully engaged? There's protected time to get this work done. That proactive outreach and planning for visits is so key to the success of care gap closures that we really need to make sure that our team members have the time to do it, that they're empowered with standing orders when appropriate, so they can pend orders or get tests scheduled for patients in advance of a visit. And really, from the provider perspective, following the guidance of the care team in terms of the patients who need that outreach, who might need that little extra nudge, and then helping to reach those reluctant patients. Ordering the labs and medications routinely when appropriate, and then asking patients if they're taking their meds at every visit. That is medication adherence, although we're not reviewing those measures in detail today. Those impact, obviously, the patient's health significantly, but also many of our payer programs. So just working that into the conversation at every opportunity with the patient. Are they having any issues with taking their medications as prescribed? Okay. And I think if we can go to the next slide, I'm going to turn it over to Dr. Colangelo, who's going to share with us some of the strategies that Premier Medical Associates has used and some of the success that they've had. So Dr. Colangelo, I'll turn it over to you.
Thank you, Tina. Thank you, Sam, also for both of you for setting the stage for my part of the talk today. So, I'm Frank Colangelo. I'm an internist at Premier, and just since we're talking all over Western Pennsylvania, if someone doesn't know Premier Medical Associates, we're in the eastern suburbs of Pittsburgh, about 105 providers, multi-specialty group, and we've touched over 100,000 lives in the eastern suburbs over the last decade. So, and all of our adult and pediatric offices have level 3 patient-centered medical home certification. So, next slide, please. And, I was asked, to address a few of the things that we're working on. Someone changed my slide a little bit, because 3 years running, we've gotten 5-star on every one of the ones except for the 30-day readmission rate. I mean, we've been fighting and struggling. We've been a 3-star for that, but everything has been the 5-star above that. But I was asked today to comment on Premier's efforts for controlling blood pressure, for the retinal eye exam, the attention nephropathy and colon cancer screening, and how we have driven success. And for each of those measures, I also want to lead into why they're important. It's not just checking a box to satisfy an insurance or to get a higher reimbursement on a value. Patients are going to benefit if we follow these guidelines, because they're all driven by evidence-based measures, as Dr. Reynolds mentioned at the beginning of the talk today. So next slide, please. So talk about colorectal cancer first. I mean, it's the 3rd most common cancer diagnosed in the United States if you combine men and women. The 2nd most common cause of cancer deaths in the US when men and women are combined. And it's expected there will be almost 150,000 new cases diagnosed this year, and almost 53,000 patients are going to die from colon cancer this year, which is terrible, because this is a disease that over 80% of these cases could be prevented if just we would do a better job on screening patients to identify problems at an earlier stage. So next slide, please. And from a Premier standpoint, this was, I think it was even before, there was a STARS bonus program that came up, but this was our first large scale population health project that we took on in our practice. At the end of 2000, 2012, we realized that our overall screening rate for the 50 to 75 population was 57.5%. And I was at a CME with Dr. Richard Wender, who became the Chief Cancer Control Officer for the American Cancer Society. And he said two things that day. He said, go back and measure your practice's screening rate. It might not be as good as you think it is. And then he also emphasized the fact that we have to provide choice to patients, saying that if your practice only offers colonoscopy for colon cancer screening, you can get good screening rates, but you're not going to get great screening rates unless you provide patients other options for screening, because not everyone can take the time or has the energy to go through a colonoscopy. So looking at some of the other options are important. Now, it took us over 3 years to get to an 80% screening rate, but we have stayed above that mark since October of 2016 and have been proud of that. So next slide, please. And when this came from the National Colorectal Cancer Roundtable, what they call the 4 essential strategies. And this became the premier mantra for doing this. You know, Tina mentioned take advantage of every single visit. I don't care if they're there today for just a head cold. If they haven't been screened for colon cancer, our recommendation is vital. Some studies have reported that the #1 reason primary care doctors get a colon cancer screening is because their primary care doctor recommended it. The reverse is also true. The #1 reason why patients have not been screened is because their primary care doctor never recommended it. So all of this stuff is a team-based sport, but this is one thing that I think falls back on the primary care doctors, that we need to take charge and make sure that we recommend that we have a screening policy. We're going to offer choice, that we're going to persistently remind patients who are delaying on screening, and that we need to measure our practice screening progress over time. So that's how we knew that we went from 57% to 80% over a 3-year period of time. So next slide, please. And when it comes to offering choice, Tina, you use the word gold standard for colonoscopy. Most experts across the country now are saying there is no gold standard for colon cancer screening. The best test is the one that the patient is willing to do, because every one of the tests, this didn't have the multi-target stool DNA test. The Cologuard is a part of it, but I always say to patients, the reason you're being screened for colon cancer is to reduce your chance of dying from colon cancer. And there's no significant difference in deaths averted per 1,000 if a person has a colonoscopy every 10 years versus having a FIT test every year. So whichever test the patient can do is the important one. And next slide, please. Premier is involved with a collaborative with a bunch of other high-performing groups across the country who share clinical and claims data. And Premier is the group on the top that had an 82% screening rate at the end of 2020. One of the things that's notable here is we have the best screening rate, but we also have the highest use of the FIT testing. So that's how I say you can great screening rates if you increase the use of FIT testing for your patients, is what I wanted to emphasize with that slide. So next slide, please. And interesting, we noticed too, a problem about the FIT test though is 366 days after the date of the FIT test, the patient is now no longer compliant with colon cancer screening. And the same thing, I mean, every single year, a patient with colon cancer who decides to be screened this year, as of the 1st of January, according to these programs, they're no longer current with their screening. So about 1/6 of our patients, so it's 8, we're using, I'm sorry, I have a question there. We're using the liquid-based testing. The PolyMedco is the FIT, the immune FIT test, immune globulin FIT test that we have in the office. So about 1/6 of our patients, about 3,500 patients, choose to be screened for colon cancer with a FIT test. And what we have noticed, on the 11-month anniversary of their last FIT test, we will mail those 300 patients who are due within the next month their FIT kit. And most of them within a week or two will return it completed. These patients have been doing this for 7 or 8 years. So the biggest effort is just mailing the kit out to the patient, but there isn't a lot of having to chase down the results because the patients will go ahead and complete it. And the other thing that we find is important, there's a big problem in this country that almost 50% of people who have positive FIT tests, every doctor knows if you have a positive FIT or a positive FIT DNA that you must have a diagnostic colonoscopy, but across the country, only 1/2 of patients who do that. So this registry has allowed us to track those patients, really get on them to make sure that they complete their order for a colonoscopy that's necessary. So this is one trick that we've used that has helped to keep our screening rates up, because we're not having the patients fall off the list because it's more than a year since their last test was done. And then next slide, please. I think this is the last one about colon cancer screening. The National Colorectal Cancer Roundtable expressed concern about what happened with COVID last year and the huge drop in the number of colon cancer screenings that occurred in 2020 because of GI labs being closed and patients being afraid to go out of the house. There's fear that in the next decade, an extra 4,500 people in the United States could die from colon cancer, and an extra 5,500 patients could die from breast cancer in the United States between now and 2030, simply because of delayed screening or treatment that occurred in 2020. So we're really trying to encourage patients to get back on track if they fell off their normal screening pattern in 2020. So next slide, please. Now, blood pressure controls. About 6 months after we started colon cancer, we were exposed to a project to try to improve blood pressure control of our patients before the insurers started to incentivize this. And on January 1st of 2013, our overall blood pressure control rate was 62%. So next slide, please. And we said, our some of the physician leaders of practice said, listen, we're already working on colon cancer screening. The docs will never do a second project at the same time. And we came back with the argument to them at that time about the high prevalence of hypertension and the fact that patients who have hypertension are very much more costly to the healthcare system than those patients who don't have hypertension. It's about a $2,000 a year extra cost for patients with hypertension. And a huge burden to the U.S. healthcare system. $131 billion was reported in the Journal of the American Heart Association. So next slide, please. And I was able to say to the doctors, the CDC says if we just can drop systolic blood pressure by 12 to 13 points, we can hugely reduce the risk that our patients will develop strokes, coronary disease, or die from problems. So this, it doesn't take a huge effort to lower that systolic just a little bit to have huge benefits for our patients going forward. So next slide, please. And just a background issue, I said the latest NHANES survey that looked at data through 2018, unfortunately, says in the United States, only 44% of patients who have hypertension have their blood pressure in control, meaning below 140/90. So this is a problem. I mean, doctors don't do a very good job of helping their patients control. And this is just in general across the United States. So this was an important focus and why we wanted to try to make a difference with our patients' health outcomes over time. So next slide, please. So, I mentioned the American Medical Group Association. Premier was part of their program they have called Measure Up, Pressure Down, where they gave us the idea for 8 different efforts that we could do as a practice. And we adopted every single one of these efforts and this is what helped us to get our blood pressure control rate from 62% to between 80 and 85% as a practice for the last 4 years. We, trained our staff on how to take accurate blood pressures. Don't round. I mean, if we see every blood pressure in the chart is 140/90, 130/80, 120/80, they're rounding, and this could have adverse, consequences on patients and us not making the right choices of medicines. That we should have a guideline. We're going to all work together. We're going to start on an ACE and add a diuretic and then add amlodipine on top of that, which controlled most of the patients. That blood pressure would be addressed at every primary care visit. I don't care if they were there because they had back pain, because they had a head cold or whatever. If their blood pressure was elevated, that at least was talked about and said to the patient, are you taking your meds? Are you watching your diet? If a patient's blood pressure is not elevated and they're started on a new medicine, that patient is seen back in the office within 30 days. Used to see frequently, they would add a medicine and say, see patient back in 6 months for physical. That's not enough. That patient, and maybe they didn't have to see the doctor. They could just come back for an RN or a medical assistant blood pressure check to make sure that the change in therapy worked. That, we had self-management plans in place. That was part of our patient-centered medical home journey. That we developed a registry to track our patients. That's how we knew we went from 62% to 80%. That every team member, this wasn't just an extra task we were giving them. We explained to them how we could reduce strokes and heart attacks, and specialists could intervene with patients. A patient, there's an order, an EHR, they see the rheumatologist and their pressure is 160/92. The specialist can click an order that says your blood pressure was above 140/90. Please see your primary care doctor to address your elevated blood pressure. So even the specialists help with this lift. We noticed if you were a patient of Premier Medical Associates, one of our specialists who had an outside primary care doctor, their blood pressure rates weren't as good as the patient who had a Premier primary care doctor. But even over a 15-month period of time, we were able to see a 15% increase in the blood pressure control rates of our patients who only saw a premier specialist. And I think that was because our specialists engaged those patients, said, go back to your doctor and have them work on your blood pressure control. So next slide, please. Many of you may have seen this. I got the web address. You'll get the slides later on. I mean, Premier, our staff loved this. They wrote a movie on the correct way to take blood pressures. This explains how you do it correctly, how you don't do it correctly. So I'd encourage, if anyone hasn't seen this, I mean, that's the address for the video that's available freely on the web. Multiple groups, even Intermountain Healthcare in Utah uses our video to train their employees on accurate blood pressure control, because they said it's the best thing that they ever saw. So we love doing that. So, and next slide. We leverage what's found in Navinet also. I mean, we get the monthly reports. You can click on the tab about blood pressure control, and we'll look for ones that had a visit, but a code wasn't dropped, they haven't been in yet for a visit. So we use this every single month to look for a pursuit list of those patients who still need to come in. So I would encourage you to explore through that list. And then next slide. And then we create off of that spreadsheet, who are the patient, when are they in, when are they coming in, what was their last blood pressure, what was the date, when's their next appointment, has the CPT code been dropped? So we populate that list with anyone who's on the wrong side of the Highmark gap list each month, which has allowed us to greatly improve blood pressure control rates in this population too. So next slide, please. Now, diabetes nephropathy screening. Give a baseline. Chronic kidney disease, some say between 20 and 40% of patients with diabetes have chronic kidney disease. In 2016, Medicare spent a lot of money on both dialysis and kidney transplantation charges. So if we could do a better job of helping to maintain these patients going forward, hopefully we can reduce the number of patients who will require dialysis or kidney transplantation. So next slide, please. And as Tina mentioned, how has Premier done this? I mean, we emphasize that pre-visit planning, and there's an order placed by the central quality team for a microalbumin on the first visit of each calendar year. And I know with the statin, it drives me crazy when I see a person who gets their meds from the VA, because you don't get credit for them being on a statin when they have diabetes. But this is one that you can either submit a CPT2 code or submit a screenshot of one of your visits from this year saying that this patient is on an ACE or an ARB. You get credit for this and can close that gap. And as Tina mentioned, you have to get to 98, 99% to get 5-star in this measure. You need to get credit for every single one of these patients. No question about that. So next slide, please. Now, I'm going off on an aside here. This measure, the medical attention for nephropathy, is probably going to be retired pretty soon. He just came out with a new measure in 2020 that I'm with our Premier doctors, and I want to make a plea across the network that everyone maybe think about this one too. We're not being measured on it yet, except for one that big purple outfit that's downtown that has a lot of patients in the area is measuring on this new measure, the kidney health evaluation for patients with diabetes. But what the National Kidney Foundation has said, chronic kidney disease means that your eGFR is less than 60, or you have a urine albumin creatinine ratio that's greater than 30. And almost 1/2 of patients with normal eGFRs have elevated urine albumin creatinine ratios. So with the old measure, it closed the gap. If the patient was prescribed an ACE or an ARB, many of those patients didn't get a microalbumin done, and we were missing a lot of these patients with early chronic kidney disease that require intervention. So next slide, please. And so this new kidney health measure is only going to be satisfied if patients both get an eGFR by having a BMP, a renal panel, a CMP done, and a urine albumin creatinine ordered annually. And the American Diabetes Association says patients with diabetes and even early chronic kidney disease, every one of them needs to be on an ACE or an ARB, and that you should strongly consider prescribing a GLP-1 agonist or an SGLT2 inhibitor to prevent their progression of their chronic kidney disease, to prevent them from requiring dialysis or transplantation over time. So this new measure will satisfy the old one. I think it will do a better job. And just looking at the Premier data, this was from 2019. We looked at it last. I mean, we have 7 adult primary care offices. Most of our patients, between 81 and 93%, had an eGFR done during that year. But at one of the offices, only 43% of the patients had the urine albumin creatinine ratio done. So, and only 60% of our patients had both of those tests done. So we've been making a big push this year, not only with the first visit of the year as a microalbumin been ordered, but also a BMP or a CMB has been put on the patient's chart by our quality team. And so we're working on trying to satisfy this new measure, which will get us, if I'm sure and Highmark and Gateway are going to start measuring us on this one. So let's get good at doing it this year is what my thought is. So, and next slide, please. So last topic, diabetes and eye disease. I mean, diabetes is a leading cause of new blindness in the United States and costs the U.S. over $500 million per year. So the other thing, if we can identify early and prevent progression, we can save our patients' vision and we can save the healthcare system dollars. So next slide, please. So our patients, I mean, we've been at this for 6 or 7 years. Every single one of them have been taught by us, haunt your eye doctor to make sure they send us back a report of your eye exam. And there are still some in the Monroe area that don't do it, that we have to, they're tired of the telephone calls from our staff to get a call. But so most of them have relented and are getting very good in terms of sending us the reports. And as Tina says, every eye exam report comes back, gets put in a registry, is either normal or abnormal. So every January, before we get any lists from any insurers, we spend the month of January entering that low risk for retinopathy code, the 3072F that Tina mentioned. And then when we get the first STARS list report, we go through that and look through every single one of them to make sure one of those patients didn't have a normal exam the year before that we forgot the data point or make part of the registry. So that's one of our things that we do every March when the first lists come out. So next slide, please. And Navanet, it seems like halfway through the year, the last couple of years, they'll do this report also that comes about retinal eye exam that we're able to look back. I wiped out the patient's name here. Those are just providers going forward, but it lets us know that this patient had that gap closed the year before, hasn't been closed yet this year. We'll compare that to our list and realize that we didn't get a report from Dr. Rock or Dr. Samay for this patient. So our staff will call those offices, get those reports. Now, many of them had abnormal exams last year. That's the reason why they haven't been closed yet. But if we find the normals, we can submit the codes too. So we leverage the information that's given us in Navanet to help to close that gap. So, and next slide. And then just, premier results. This is my last slide. Colon cancer screening. This is, we hit 90% of our Medicare Advantage patients had it completed. Blood pressure control 88.4%, the diabetes nephropathy at 99%, and diabetes retinal screening 86.4%. That was the lowest. We're usually close to 90% with diabetes retinal screening. I think COVID kept some patients from going to the eye doctor last year also. So we're really pushing patients this year to work on that one too. So that was my whirlwind. Hopefully I left enough time for the Grove City team here, but wanted to share why and how we've improved the performance on these metrics over time. So thank you.
Thank you, Frank. If you can stick around, we'll see if there's some questions at the end.
Great. I would like to introduce our team from Grove City Primary Care, who's going to tell us a little bit about some creative things they've done around colon cancer screening. And so do we have Cindy, Nicole, and Jenny on the line? You might be muted.
Can you hear us now?
Yes.
We can, thanks.
Can you hear us?
Yes.
We can.
Okay. All right, good. This is Jenny. I'm the RN here at Grove City, and our office is pretty proactive. We're all coming up with strategies for the gap closures for our patients. Our patients seem to be more engaged too, because we're talking about it several times. We're talking about it in chart prep. We're talking about it when they come in to the appointment, and then we're talking about it before they leave too. So we're making sure we try to close all those gaps and mention them. And we also have monthly meetings and try to work as a team and go over everything and see if anybody has any input on anything.
And this year, we started a raffle basket for the screening. We started it in March. It continues until August. We have 2 baskets. We have a male and a female basket. For every screening that is completed, the patient receives entries in the basket. 1 entry is for a FIC kit, 3 entries is for Cologuard, 10 entries for a colonoscopy. And so far, since this started, we have 52 patients in our entry work. This is Nicole, and she's going to tell us our process. We started in February by running the need for colorectal screening report in Epic. We sorted through the list and outreached the patients that needed these. We try and get them to do the colonoscopy, but if they do not want to do that, then we will mail out the fit kits for them. In April, we ran the CRISPR report and printed all the open orders and gave them to the appropriate staff for outreach and completion. If we do send out a fit kit, we add a 2-week remind me for everyone that is given, so we can follow up to make sure that they have completed the testing. During chart prep, we try and call the patients and go over health maintenance and to have fit kits ready for the appointment. Throughout the year, we also work off of SharePoint. That's our process for the what we've been doing this year.
Great, thanks for sharing. How have your patients reacted so far?
They're
In
excited.
terms of that proactive, yeah?
Yeah, they like it.
Well, that's
Thanks for
fantastic.
being creative.
This is a fantastic approach, and we appreciate you sharing it. There's something in there for all of us to think about in terms of how we might change a process at our own offices. So thank you so much.
You're welcome.
All right. Well, we do have a few moments left here. Let's open things up for questions. You're welcome to chat your questions in, or you can unmute your line and ask.
Hi, this is Dr. Peter Jaganis, Family Practice Medical Associate South. I'm still confused about the fit testing with regard to our cards in the office say fecal immunochemical test. We're doing cards, but I've also heard that that's not really a fit test, that the liquid-based test is what's necessary. I still don't have clarification on that.
I'm not sure I can answer that. Frank, do you know the?
Yeah, I think they both, some in the literature, some say that the liquid testing is better, but they both do satisfy the metrics. So that, both the card-based system and the, if it's the high sensitivity guaiac test, or I forget, I'm blanking on the name because we haven't used it for a while, but it's, they both satisfy the measure. So.
Okay, thank you.
Frank, I had a question for you. At the beginning, we kind of talked about the various challenges that occur at the various steps in the quality gap closure process, from identification all the way through the claims processing. I'm curious from your perspective, since you all have really developed some very mature systems, where would you say you still find the biggest challenges right now in terms of addressing that gap closure process?
Well, this has been both, re-educating our care team members and our primary care doctors. In the past 5 years ago, you would see all the time across the EHR banner, don't ever ask this patient again about breast cancer screening or colon cancer screening. They don't want to talk about it. And, saying to patients, to providers, yes, this is shared decision-making. We want to do this, but it's important for you to address this with the patient. I know you have never been wanting to do this in the past, but by chance, has anything changed in the last year? Maybe their next door neighbor developed colon cancer, or they had a cousin develop breast cancer. Someone who has refused to do anything long-term, they change their mind occasionally. So at the same time that you're respecting the patient's wishes and decisions, that it's not, oh, they refused this, so I'm never going to talk to them about it again. I mean, I think it took a while to get the doctors out of the habit of saying, I'm never going to bring this up again because the patient doesn't want to hear me talk about it, but just, framing the question in a polite way, but it was important to bring it up on a regular basis with these patients. I think that was a lesson that was hard to get through to a lot of people. So.
And that's a great takeaway for us. I think about the conversations around smoking cessation, that after a while, it feels like we're not making any progress, but then sometimes that patient comes in and has a change of mindset.
Mm-hmm.
Very good. There's a question here for our Grove City colleagues. How soon do you follow up with patients once the fit kit is ordered? And if they haven't completed it, do you follow up with them again? If so, when? Do we
From
still
Grove.
have?
Here we go.
This is Cindy from Grove City, and we just wanted to add one thing. Throughout the day, we communicate through the secure chat and Epic.
So that's a great way that you communicate with each other. You may have answered this question. We didn't hear your response. Is how soon do you follow up with patients once the fit kit is ordered?
2 weeks.
2 weeks.
We do a remind me in 2 weeks, and then we reach out to them to see why it's not completed or what's going on with it.
Fantastic. I like that. Yeah, it's one of the things that I've been doing more recently is when we do give them the fit kit, I encourage them to complete it within the week. I said, don't let it sit around because then you'll forget about it. I said, so make a goal to finish it right away.
Yeah, Sam, I always tell them take it home and sit it on top of the commode so you don't forget
There you
about
go.
it. So that's the, yep.
Other questions? Well, this is great. And I want to thank everyone who contributed to this. And I also want to do a shout out to Teresa Petroselli, who does a lot behind the scenes to make this webinar happen every month. And just thank you, Teresa, for all that you do. And our final slide here today is for those who would like to register and claim credit for the CME activity today, you can jot this down, DUGNES to 412-301-9919. So again, that's DUGNES to 412-301-9919. If you text that there, you'll get a response and that will register your participation. All right, we are planning for a webinar next month on June 2nd, and the topic will be around enhanced community care management and palliative care, and I hope you can join us. Well, thank you everyone and enjoy this beautiful spring day.
Thank you.